A very good evening. This evening has progressed well, and now it's time to show respect to the cause that makes us who we are, our academics. To start off the scientific session, I invite a great academician who graciously accepted the invitation, who we all respect as the Professor and Head of Department of Medicine, Professor Dr. Ann.Meet sir. All clothes are small for him, who still burns the midnight oil for the betterment of his knowledge. Sir, kindly come forward to chair the session.
He has also already been introduced officially, and I will not delay much further in his talk, which is on GI column acute abdomen. Sir.
So thank you, Dr. Mittal, for getting me this opportunity, and the Dr. R.N. Singh, my class fellow in the school days. I missed him. And there were many people who excelled. And when I look credential of my predecessors, I don't stand anywhere. So this is nothing. And that's why I'm going to start something very primitive part of medicine, to which you must have seen figure of Hippocrates palpating the abdomen. And this is a true story. There are two true story with case report. And one of the presentation I did in University of Moscow about 10 years back, this was the presentation taken from there. And this is about my teacher. My teacher, who was professor of cardiology, who was former dean, former director, one of the brilliant student of KG Medical College at that time. And I would name him because of professional reasons, and we shouldn't take the name, but just to put you the background, how such a simple complaint could be so complicated at a time and can be treated without any costly medicine. And that led to us think of what are the non-digestive causes of acute abdomen. All of us must have felt in our lifetime this could be the sole presentation. Historically, there were only two diseases, the mother of the disease. One was the pain, when we had no language. I'm talking of 10,000 BC. Aurignacian man for the first time in the history, when they perceived pain. And we had only one medicine. No medicine would be granted that gratia unless you relieve the pain of a person. So we started with opium alkaloid. Opium has that quality not to only take care of the systemic pain, the somatic pain, the CNS pain, intra-abdominal pain, anticholinergic action, opioid action. You ask anything in pharmacology, if your teacher has taught you about the these are the opioid receptor, you get the distinction in pharmacology. So this retired professor of cardiology, 75-year dean, former dean and director of a reputed institution, suffered with pain. Now look at the language: dull, aching, persistent in right hypochondrium. That was the presentation. And all of us see every day. This was in the past history, he had well-controlled hypertension and diabetes and was taking amlodipine. He was the first right to like Adalat, 1981, when amlodipine had a cost of 25 rupees. 25 रुपए की मिलती थी 1980-81 में. तब amlodipine कैल्शियम चैनल ब्लॉकर हाइपरटेंशन के लिए हिंदुस्तान में आया. And he was on beta blocker, he was on statin, he was on glimepiride, he was on metformin, he was SGLT2 inhibitor. On examination, he had normal vitals, and you can think of professor of medicine himself, how meticulous he would be. Abdomen was soft, no organomegaly, normal GBP. GBP is the stethoscope of the क्लिनिशियन एंड जनरल प्रैक्टिशनर. पैथोलॉजी भी उतनी ही मुश्किल सब्जेक्ट होती थी. एंड माय टीचर ऑफ पैथोलॉजी, प्रोफेसर ब्रह्मानंद दुबे, can talk hours together on only general blood picture, looking at the morphology of the RBC, the outer ring of RBC, the content of hemoglobin, its appearance, and can tell you lot many causes. So I had a normal white well GC, soft abdomen, no organomegaly, normal GP, normal count, liver function normal, all relevant biochemistry were normal, X-ray chest was normal, ultrasound abdomen was normal. Or Dr. Madhuri Bihari, the former professor in her department of neurology at All India Institute of Medical Science at Delhi, used to tell, when CT, MRI, everything is normal, then neurology start. So most of the time patients come in. So this professor had already these problems, and still we could not reach to the consensus of diagnosis. What was the clinical course? He received antispasmodic, antacids, PPI, metronidazole because the pain was in the right hypochondria. And the first prescription would be from any one of us, would be a combination of metronidazole and any antibiotic, quinolone could be, which he had, which partly relieved the symptom. But pain recurred after 1 week. Professor of gastroenterology, who was his friend and also retired professor, who established DM gastroenterology in this country other than PGI Chandigarh. That was the credit, that was the credential. So that professor of gastroenterology examined him. He reviewed all the old investigation, ultrasound, repeated liver function test, pancreatic enzyme were all assessed. Patient was reassured कि डॉक्टर साहब आप बेकार में परेशान हो रहे हैं, हाँ कोई तकलीफ है, कुछ खा पी लिया होगा. NGI specific calcium channel blocker, mevaverine, one of the very important drug for chronic IBS was given, tranquilizers were given, and also they did not relieve the pain. अब क्या करें? देखिए जीपी का काम कितना मुश्किल होता है. टर्शियरी इंस्टीट्यूशन में गए, सारे जांच हो गए, तब बड़े डॉक्टर साहब ने बड़ा प्रेम से देखा, 5-6 हज़ार फीस ली. एक हमारे टीचर भी जिंदा हैं, उनकी कंसल्टेशन फीस बनारस में है 10,000 रुपये है एक मरीज की. पूरे 45 मिनट 1.5 घंटा मरीज देखते हैं, A to Z देखते हैं. जीपी बेचारा, दरवाजे पे कोई आदमी खड़ा, एक ने पैसे का मरीज जांच कराने को तैयार नहीं. पॉलिटिशियन बहुत नाराज, एडमिनिस्ट्रेटर बहुत नाराज, मोहल्ले वाले बहुत नाराज. तुरंत देखिए, तुरंत दवा दीजिए, ठीक नहीं ठीक हो गया तो डॉक्टर साहब बहुत बेकार आदमी, बड़ा पैसा चूसते हैं. विद दिस ऑल इन्वेस्टिगेशन, एनीवन ऑफ कैन यू ऑफर अ डायग्नोसिस टू मी? आवाज़ बुलंद बताइए जरा सा. Root pain, very good. One diagnosis of the cord compression, root pain. So coming back to the next presentation of the part, that you said a wonderful part. Surgical opinion was Professor B.N.S. Bhatnagar, my another very senior teacher, who was FRCS, who worked at Los Angeles, and he was the head of the critical care unit. He examined. And then at that time, CT abdomen was done, endoscopy was suggested, and that was also normal. Dull aching pain continued, no relation to the posture. अब देखिए, back spine ठीक ठाक है, because posture didn't. Root pain will always be triggered when you change your posture. Muscle spasm would be aggravated when you change your posture. Bladder and bowel was normal, therefore it was not a compressive. Intradural, intramedullary compression pathology was ruled out. अब क्या करें? What next? अब कौन सी जांच करें? कहाँ जाएं? 75 साल के फार्मर प्रोफेसर ऑफ कार्डियोलॉजी, कितनों को स्टेंट लगाया, कितने की CABG करवाई, कितने के ट्रांसप्लांट करवाए, कहाँ जाए बेचारे ये. Surgeon insisted on CT review. Normal. और CT अगर बढ़िया करने वाला है तो स्पाइन दिख जाती है. And they disclosed. Incidentally, this professor of radiology happened to be my son-in-law, young son-in-law. And then he was another brilliant person who left. He had a 16 gold medal in his career. He left all specialty. He joined radiology as a specialty. He suggested, नहीं, आपने पेट तो कर लिया, एक रेडियोलॉजी का सिद्धांत है कि आपको चेस्ट भी देखना चाहिए. So here is the Pandora box. Now diagnosis from anybody apparently looks normal. Anything wrong in this CT? Slightly pleural thickened, but अब क्या हुआ? There was suggestion of pericardial thickening. So suddenly, because he himself was the professor of cardiology, दो लड़के बगल में खड़े थे वहाँ, बोले अरे ये तो बड़ा गड़बड़ हो गया. सर चलिए अभी तुरंत देखते ही, ये तो पेरिकार्डाइटिस लगती है, पेरिकार्डियल इफ्यूजन लगता है, इसको इको करते हैं. So this was the echo done. It did not show fluid. In spite, there is this small rim. यहाँ देखिए ये जो rim है, छोटी सी rim है. Despite of the fact, there is a small rim which thinks like a fluid. Can you see my? There is a small rim of the fluid. क्या काम नहीं हम लोगों ने किया? इतनी कहानी हो गई, एक काम नहीं हमने किया. डॉक्टर साहब कह रहे ECG, उससे भी सस्ता एक काम हमने नहीं किया. ये काम हमने नहीं किया. आपने पूरी घटना में देखा. और वहां जो CMO साहब थे वो बेचारे रेडियोलॉजी के आदमी थे और बड़ी जोर से उनको डांटा. बोले आपने आला, आपका आला कहाँ है? अब रेडियोलॉजी का आदमी जिंदगी भर तो उसने, अब आला क्या करेगा लटका के. We did not auscultate, he did not auscultate himself. और ये प्रश्न हमने उनसे किया कि सर सब कुछ तो हो गया, हमने, आपने सुना? बोले नहीं सुना. आला कहाँ है भाई, आला ले आओ. प्रोफेसर ऑफ कार्डियोलॉजी पूछ रहा है. कहाँ पूछ रहा है? कार्डियोलॉजी डिपार्टमेंट के अंदर, जहाँ की हम उसका इकोकार्डियोग्राम कर रहे हैं. मेरी थीसिस दुर्भाग्यवश पेरिकार्डाइटिस में. मेरे टीचर, मेरे एग्जामिनर जो थे, मेरे गाइड, वो लेटे हुए हैं, वो बीमार हो गए, वो भी कार्डियोलॉजिस्ट. None of us ever put a stethoscope on his chest, and the diagnosis was massive pericardial rupture, and therefore it was not worth to aspirate, and because it was not worth to aspirate, this is the physical sign in acute pericarditis: friction, rough, scratchy, leathery sound during systole and diastole about the apex. May be transient from one hour to the next, and is present in approximately 50%. So even you could have put a stethoscope in 1 or 2 visits, you might have been able to miss it, because this is not always there. It's a fibrinous inflammation of a pericardium, and the moment fluid appears, rub disappears. That's the story behind it. ECG may be changes, maybe non-specific STT changes could be seen in hardly 20 to 30%, because epicardial fat is not removable. That's what the cardiologists know about it. Since it was my thesis, MDC, so I know it a little more detail. All electrocardiographic changes which you get into the chest lead, not into the limb lead, is because of the epicardial involvement, even in coronary heart disease. Since it was not there, so ECG may be or could be absolutely normal. So this friction rub was diagnosed.
How long that symptoms remain when the friction rub was found?
3 to 6 weeks. Every story went about 3 to 6 weeks.
I think that it is usual that the 3 and 6 weeks a person is having pericarditis and it is not having
So the pain was a referred pain. This was the pain which was at the, no, if you look at the whole previous picture, it was at the base of the heart, just above the diaphragm, onto the right side, and therefore the intercostal, the transpleural plane which we assessed always, the nerve, the twig of the nerve which gets irritated and patient gets pain. Otherwise also, as I said in the beginning, 50% time you may not get rub. So pain may not be there. If the rub is not there, that's why the pain used to disappear. आप मास्क हटा सकते हैं. अब यहाँ अधिकारी लोग नहीं है, प्रिंसिपल साहब हैं, अधिकारी गए, सीएमओ साहब गए.
As soon as the fluid appears inside the pericardium, most of the time the pain disappears.
This is what I said. Exactly, this is what I said in the beginning. The pain would disappear as the fluid would appear, and that's why. What was the idea? What was the lesson? The take-home message? You must routinely put your chest-piece stethoscope on the patient, invariably, irrespective of the truth, whether patient belongs to one specialty or other specialty. और इसलिए जो लोग आला लगाते हैं वो बड़ा पवित्र कार्य करते हैं. और आला सिर्फ जनरल प्रैक्टिशनर ही लगाता है धर्म की तरह. कोई माई का आला नहीं लगाता. जो गैस्ट्रोएंटरोलॉजिस्ट है वो बहुत बड़ा वाला आला पेट के अंदर डाल देता है तो उसका 1,500-2 हज़ार रुपया मिल जाता है. जो कार्डियोलॉजिस्ट है वो दूरबीन लगा देता है, उसमें 2-2.5 हज़ार मिल जाता है. अभी बिना पैसे का काम कौन करे? And that's why how important are general practitioners, how important you are, how much indispensable you are, and nobody, no investigation can compete with your intelligence. So I appreciate Dr. R.B. Dwivedi, who at least said that certainly pericarditis is one disease which comes and keeps on going. And we started looking at the etiology. Was it uremic? No, because biochemistry was normal. Could it be rheumatic? Answer is no, because he was a 75-year-old person. Rheumatic fever is unheard of without valvular lesion. Could it be because of the other metabolic disease? Answer is no. So it has to be acute, benign pericarditis which comes on its own, disappears on its own. So subsequent time he received only, he took himself, उसने कहा पहले तो ये बात सुन ली साहब कि वो उनके विद्यार्थी थे, उन्होंने इम्तहान डीएम में लिया था कि नरेश त्रेहन के यहाँ चलें, सर्जन आदमी हैं, उनका रिकॉग्नाइज किया था. अपोलो जाएं, हैदराबाद जाएं, पानी कौन निकालेगा, इन्फेक्शन कहाँ होगा. और अगर स्टेथोस्कोप न लगाया होता और मेदांता चले गए होते, पानी निश्चित निकलता, इन्फेक्शन ज़रूर होता, पेरिकार्डियक्टमी होती, और भगवान जाने पता नहीं क्या होता. जो बेचते थे दवाएं दिल वो दुकान अपनी बढ़ा गए. So that would have been happen. How important general practice. Let's look at another story and then I'll finish it off. 65-year retired male diabetic patient presented with severe pain in epigastrium. ये देखिए, ये दूसरा, एक तो वो मिला आपको, pure cardiac cause presenting as acute abdomen. This patient was hypertensive for 4 years, controlled on the blood pressure 130/76 with amlodipine, metoprolol and statin. Antacid, PPI, antispasmodic, H. pylori did not relieve it. Blood biochemistry, CBC, GBP, routine analysis, LFT, liver enzyme, lipase, amylase within normal range. ECG was normal. पिछली बारी गलती हो गई थी, ECG नहीं, तो इस बार ECG भी कर लिया. Imaging, USG, X-ray, plain abdomen, standing posture, X-ray chest, CT chest, all normal. GI endoscopy was normal. Acute abdomen continued, persisted. This is what my respectable teacher, जिसका मैं भी पहले नाम, संत हम उनको कहते हैं, ऐसे अध्यापक मेडिसिन में साधु महात्मा के नाम से होते हैं, प्रोफेसर पी के श्रीवास्तव, डॉक्टर जानकी प्रसाद के छोटे भाई. This word he coined to me when I was in 3rd year. What is the language of pain? दर्द की भाषा क्या होती है? Is it a burning pain? Is it a bloating pain? Is it a sense of fullness? Is it a language? And every word has got a connotation with a diagnosis. It is a squeezing pain, precordial squeezing pain, epigastric squeezing pain, which could be ischemic pain. Is it a piercing pain, perforation pain, pancreatitis, stabbing pain? It's a heaviness pain or oppressive. And look at the distribution of the pain. It could be the epigastric area, which is maximum, followed by the periumbilical area, then lumbar area. So most of the pathology of the acute abdomen would be related to upper GI. So what happened in this pain? What are the medial लिखा हुआ मिस correction है उसको medical causes of acute abdomen, non-surgical abdomen. It could be intra-abdominal condition where you do not require your knife and you do not need a consultation from surgeon. Gastroenteritis, infective colitis, mesenteric adenitis, वायरल फीवर बहुत सारे परेशान करते हैं अल्ट्रासाउंड वाले. मरीज साहब ये हमारा लिम्फ नोड बढ़ गया, सब 1 मिलीमीटर से नीचे, 1.5 मिलीमीटर, 2 मिलीमीटर, घटता ही नहीं. यंग गर्ल्स, पीडियाट्रिक एज ग्रुप, नॉन स्पेसिफिक lymphadeninitis, don't treat it, don't get disturbed, it would disappear on its own. Typhoid fever, we all have heard it. Acute viral hepatitis, congestive hepatomegaly and liver tumor. But what are the intrathoracic causes? ये medical causes हुए. ये हमारे जनरल प्रैक्टिशनर के लिए महत्वपूर्ण है. MI can certainly present. If it is the inferior wall MI, it can certainly mimic epigastric pain, basal and lobar pneumonia. So you need a stethoscope to listen. Lung abscess, pericarditis we talked about, spontaneous pneumothorax. All these investigation can reveal, but then you need a stethoscope and the basic investigation. And this is the huge list. I would not read it, I'll just quickly pass it on. This is what meant that there have been, this is French Index of Differential Diagnosis. ये दुबे जी आपने जरूर किताब देखी होगी. मैनुअल, इतनी मोटी किताब, दुनिया की जितनी बीमारी हो, French Index of Differential Diagnosis. So you can start from epigastrium to the lumbar region to the basement and to the top. लब एंड बेली की किताब जो किसी ने सर्जरी में पढ़ी होगी, उसमें ये जरूर दिखाया गया था. So what happened? What could be the cause of now acute abdomen? Could be metabolic causes, porphyria. आप लोगों ने जीवन में जरूर 2-4 केस देखे होंगे. Change the color of the urine and the patient, and this pain also doesn't remain all the time. This comes and goes, but it's a curable cause, treatable cause. Uremia, diabetic ketoacidosis. 40% patient of diabetic ketoacidosis, acute abdomen would be a presentation, and you may not get any damn thing in the abdomen, but for the hyperglycemia and ketone bodies. Neurological cause, sensory radiculopathy. Somebody was talking before. You should examine the back. You should examine and herpes zoster. छिपा हुआ रहता, 1-2 दाना कहीं दिख गया, बड़े चुपके से धीरे से, बड़ी लोगों की बेइज्जती करवा दिया उसने, और तब आपने कांख में देखा 1 दाना निकल आया. हर डॉक्टर की उसने जिंदगी खराब की होगी. And suddenly came out to be herpes zoster. 100% curable. What is the advantage? What is the golden period? You prescribe Zovirax, herpes, and the patient responds, but should be done within the first 3 days of the diagnosis, within the incubation period. Incubation period के बाद दिया, सारी जिंदगी गाली खाएंगे आप, क्योंकि ये दर्द post herpetic neuralgia, one of the worst thing can happen anybody on this earth. So that is the advantage of cyclovir giving for the 10 days. So what happened in this patient? Spine and CNS, temporal lobe epilepsy. कितने लोगों ने देखा है? This was a very favorable topic of my Professor Katiyara, Professor of Neurology, patient presenting with the seizure disorder. Temporal lobe epilepsy, exclusive EEG changes in patient occurring with acute abdomen. Patient developed acute retention of urine. His EEG was normal. Opioids and antiepileptic did not relieve the pain. Developed acute retention of urine. Normal renal profile. Patient now developed backache followed by retention and paraparesis. Now is the diagnosis. This acute abdomen started not with root pain. Why? Because patient had intramural, intra-cord pathology. So he did not have a root pain. रूट पेन तब तक नहीं होगा जब तक कि डिस्क प्रोट्रूड हो करके इंटरवर्टिब्रल फोरामिना से जा करके एंटीरियर रूट को कॉम्प्रेस करेगा, डॉर्सल रूट को कॉम्प्रेस करेगा नहीं, तब तक दर्द नहीं होगा. So it was intramedullary pathology, that's why it did not, and this was the result. Here is the diagnosis. And the biopsy showed non-secretory plasmacytoma. So the reward was entirely different. That is the beauty of examining from head to toe, and that's why I got this slide for general practitioner. To revisit your clinical skill, to establish your value, and patient come back to you, कह रहे डॉक्टर साहब वो तो संजय गांधी गए वहाँ आपने कर लिया इलाज आपका. So the treatment is surgery, chemotherapy, radiation. This is what happened. This is the abdominal pain, could be visceral pain, could be somatic pain, could be referred pain. हमारे डॉक्टर पी के श्रीवास्तव साहब कहते थे विलियम ऑसलर का, pain is there, cause is there, pain is there, cause is somewhere, pain is there, cause is nowhere. Supra sagittal area. This is the whole issue. And abdominal pain, which is so simple, could be related to the heart, could be related to the lung, could be related to the spine, metabolic, aorta. And once you remember all these three review, you are the winner. So the clinical skill, what is the final message? Revise history again and again and again till you reach the final diagnosis. फिर वापस आइए, फिर मरीज के पास बैठिए, फिर उससे सुनिए. हमारे मालवीय जी महाराज भाषण में कहते थे, श्रुत्वा सर्वधर्मस्य, सभी लोगों के धर्म की बात सुनो. श्रूयताम सर्वधर्मस्य श्रुत्वा तत्परिधार्यताम. और उसके बाद अगर आपकी आत्मा को कोई चीज़ नहीं लगती है, दूसरे के लिए नहीं करना चाहिए. आत्मनः प्रतिकूलानि परेशान न समाचरेत. This is the final message. So you should go back for the abdominal inspection, palpation, percussion, auscultation, and this is the father of the medicine. We should all respect him. Still he has got all the respect, relevance, reverence for the clinical skin. We should all bow against him. Thank you very much for listening, and it is on the demand.
Thank you. दो आपने बहुत इंपॉर्टेंट कॉल बताया, पेरिकार्डिटिस एंड क्वाड. पेरिकार्डिटिस की बात हो रही थी. हम लोग के यहाँ मेडिकल कॉलेज में भी देयर वाज वन स्टूडेंट एंड पेरिकार्डिटिस प्रेजेंट इन मेनी वेज. फीवर ऑफ अननोन ओरिजिन, यहाँ को कुछ नहीं मिलेगा, हल्की सी पेरिकार्डियल फीवर रहेगा. वी हैड अ स्टूडेंट हु हैड फीवर हर जगह कुछ हो गया, सीटी शेयर नहीं कराया, आया एक्सरे में हल्का सा लगा गया, आला रखा, पेरिकार्डियल रक्त थी, टुबरकुला निकला, बाद में उसका सब इलाज होता. पेरिकार्डियल डिजीज इज वन ऑफ द डिजीज व्हिच does not have a very definitive presentation and should be looked for जब आपको कहीं कुछ और नहीं मिल रहा. That is a very important cause of even chest pain and abdominal pain. और जहाँ तक स्पाइन की बात रही, आपने बताया एओर्टा की कॉजेज. मैं पहले में डिसेक्शन सोचा कि डिसेक्शन भी इस तरह कुछ abdominal प्रेजेंट कर सकता है, बट डिसेक्शन ना होकर उसमें ट्यूबरकुलोसिस निकला. So any questions from the audience?
So thank you. आला जो लटकाया हुआ उसको वापस लाइए, गले में पहनिए और एक बार फिर दुनिया के सबसे अच्छे क्लिनिशियन बन जाइए. थैंक यू.
Please wait, sir. I request our chairperson to kindly present a memento to our speaker.